Bismillah ar-Rahman ar-Rahim. Today our subject is about post-infectious glomerulonephritis. I am Professor Nariman Fahmi. I wish in this lecture we can reach is about the definition of the problem and the pathogenesis behind it, the main clinical features, management, and a small case scenario for the discussion of the problem. First of all, we should remember that the kidney has a very important role in controlling the balance of fluid and electrolyte inside our body. It's controlling the acid base and the passage of the waste products outside the body. It's controlling our blood volume and blood pressure. Each kidney, as we can see in this small picture, is formed from a functioning units which are called nephrons. We have about 1 million nephron in each kidney, and the kidneys is usually the nephron is formed from a tuft of capillaries that is connected to tubules. Each part of a tubule has a function, and the function of the glomeruli is the filtration. Anything comes from whole blood will pass through these small tuft of capillaries that is distributed in both of our kidneys. This small tiny ball-shaped structure that is composed of blood vessels is involved in filtration of blood and formation of urine, and the tubule will carry these material outside of the body in form of urine. So any damage to these small tiny blood vessel structure can cause what we call a decrease in filtration rate, and there will be accumulation of the waste products, blood volume, fluid inside the. Any disease of the kidney that affects the filters or glomeruli is a very serious problem because it is interfering with the basic function of the kidneys. One of the oldest recognized renal problems was the post-infectious glomerulonephritis. Previously, it is called post-streptococcal glomerulonephritis, but now they found not only the streptococci is causing the problem, so other infectious agents like staph and others have a role in the this disease, so it is called now acute post-infectious glomerulonephritis. This is a small picture showing the streptococci. لاحظون مثل المسبحة. Not any type of streptococci can cause immune-mediated destruction of the glomeruli. There is a specific pathogenic strain of group A streptococci. It is called nephrotogenic strains M types اللي هي تشمل 1 2 4 12 18. It's not a big deal to know the numbers, but we should remember that there are specific nephrotogenic strains of the streptococci that can cause damage from a specific mechanism to these small capillaries in our kidneys. Other pathogenic agents like staph, gram-negative bacteria could also involve in this problem. The exact mechanism that is going to damage our glomeruli is immune complex formation. Immune complex formation. We see here that antibodies that is formed in the body find the target اللي موجودة على الglomerular basement membrane with the complement, especially the alternative pathway اللي هو C3 activation can destroy the glomerular basement membrane, causing damage to the kidneys. إذا يجي عندنا يدخل مايكرو أورجانيزم يسوي infection مثلا to the tonsils أو skin مثل النفروتوجينيك strain M type of streptococci. فبعد فترة تتكون antibodies. الانتيبوديز تجي ويا الكومبلمنت على الجلوميرولار بيزمنت ممبرين وتسوي لي damage to the glomerular basement membrane by activation of the cascade of the anti-inflammatory cascade. Then infection does not occur in the kidney but in a different part like the skin or the throat مثل ما نلاحظ في هاي البيكتشر. This disorder begin to develop 1 to 2 weeks after untreated throat infection or skin infection. 3 to 4 weeks after untreated skin infection. And the disease is usually occurs what we call it in school age children بين 6 سنوات إلى 10 سنوات. أوكي؟ يصير عنده بالهيستوري بلاعيمة توجعه أو عنده التهاب وراها بفترة الطفل تظهر عليه علامات. لكن شنو هو اللي حيصير أو لما الفلتريشن برودكت أو اللي نسميها الجلوميرولاي it's involved going to see inside the patient. فإذا لازم نذكر إنه هي بيها 3 phases. الفيس الأول اللي هي infection اللي صار in past history. بعدين يصير عندنا period اللي هي الانترفال there will be nothing. After that start the patient having what we call it nephritic presentation, not nephrotic. And the severity of the renal involvement will depend on the severity of the immune system that is triggered by the infection. So the patient could be asymptomatic or he could have renal failure. فإذا الجlomeruli when it is going to be damaged, first thing we can see there is blood in urine, RBC in urine. This is called microscopic hematuria. But sometimes it's a very severe immune activation from severe infection. So there will be loss of the kidney function, accumulation of fluid, start to have dark urine, edema, and so on. عام 1927 ريتشارد برايت قام بشرح عن acute glomerulonephritis فقال إنه المريض الذي يأتي عنده coca color urine hematuria there will be decrease in urine output because of the decrease in the filtration rate and because of accumulation of the fluid he will have edema. لاحظوا من الفيس مالته كله edema. There will be salt and water retention leading to hypertension. This is called glomerulonephritis. In this picture, we can see the patient is having periorbital swelling واليورين اللي مجمعة بالباقي يكون أحمر. فإذا هذه من مميزات الجلوميرولونفرايتس. إدراره يكون كميته إذا نجمعه قليلة لونه يكون طوخ على حمار جوزي والطفل يكون عنده periorbital swelling كما نلاحظ in this. فإحنا لما نيجي نفحص اليورين اللي هذه واحدة من أهم الطرق بالdiagnosis we can see urine analysis demonstrating RBC with cast. There will be a little of protein in urine in إضافة إلى other things that can pass in the urine like the polymorph leukocytes نسميها granular cast. فإذا RBC when we see RBC and the RBCs تتحول إلى أسطوانات نسميها كاست نتيجة الباسج بالتيوبيول ومال the protein وgranular cast. This is called urine analysis of glomerulonephritis. The patient because of accumulation of fluid in the body will have what we call dilutional anemia which is usually normochromic anemia. لاحظنا انه بالصورة الكرتونية الانتيبودي والكومبلمنت is involved. فلما نيجي نفحص C3 اللي هو يدخل بالalternative complement pathway activation نشوفه قليل. فهذا يعتبر one of the most important diagnostic tools in this problem. patient يجي عنده أديمة يورين مالته جوزي أسوي له تحليل مال urine يطلع ب RBC وكاست. Next thing I want to do what? I want to see if there is defect in the complement. فنلاحظ ال complement will be low, but this low complement should go to normal after 6 to 8 weeks. If it will not go to normal, that means we are dealing with another disease. This is very important. فهاي الفترة الزمنية اللي حيرجع بيها الكومبلمنت إلى الحالة الطبيعية لازم نتابعها، حتى إذا بقت low لازم نسوي للبيشنت another management like biopsy حتى نشوف which type of problem is we are dealing inside the kidney. ذكرنا إنه البيشنت could have untreated infection in the tonsils or skin. فبالنسبة للتونسلز حتى نعرف إنه هو أكو ستريبتوكوكاي لو لا، ممكن نسوي له swab for culture and we can see if there is increase يعني in addition to throat swab if there is an ASO titer is commonly elevated after pharyngeal infection. أما إذا كان عندي cutaneous infection فممكن نلاحظ أنه there will be anti-deoxyribonuclease B level it will be increased. فإذا واحدة من الدايجنوستس اللي نسميها احنا نسوي له throat swab ندز ASO titer وندز إذا موجود عنده anti-deoxyribonuclease B level. Regarding the management, المانجمنت it should be conservative management. الجلوميرولاي تعبانة. It cannot control the amount of fluid and electrolyte in the body. So we should try to help the kidney. We give the patient antihypertensive to control the accumulation of salt and fluid inside the body, and we give him advice to the family not to give him salt and fluids, restriction of the salt and fluids, and we should check his blood pressure to control it. We start to give him a sort of diuretics like Lasix or thiazide to increase urine output and decrease the edema. If we have a throat infection, we should treat it by antibiotics or skin. نرجع نقول إنه التريتمنت is focused on relieving the symptoms by restriction of the salt and fluid, by giving antibiotics for infection إذا كان streptococcal infection or other infections, by controlling of blood pressure, by giving diuretics to decrease the edema, and controlling the swellings. These are the most important things that we can do. It is called conservative management. Regarding the dialysis, as we all know from previous lectures in other years, الدياليسيس تعتمد على إنه how we can by conservative management control our patients. فإذا ما قدرنا نسوي له uncontrollable hypertension, continuous anuria, if the patient's having rapid increase in his renal incidence يعني البلاد يوريا وكرياتينين ده يصعد بسرعة، البيشنتس بدأ يصير عنده uremic symptoms, uremic encephalopathy or pericarditis. In these conditions, acidosis that cannot be controlled, electrolyte that cannot be controlled, we need to do dialysis for the patient. فيعتمد على the course of the disease we are dealing with. Fortunately, the disease is usually mild and it will typically recover within weeks in 95%. So this is a good news for the patients who will have the disease. And actually it is very rare to recur. The problem, it will not recur, not like nephrotic syndrome which has many relapse remissions. This occurs once. Just one thing with management, when we are going to give antibiotic to the patient, not to decrease the course of the disease, but to prevent the spread of the disease of this type of microorganism to another family members they are dealing يعني living with the patient، لأنه هاي specific strain ممكن تنقل إلى another patient عنده قابلية أنه يصاب بنفس الديزيز. Complication: he could have heart failure, pulmonary edema, hyperkalemia, hypertension, and he's already in acute renal failure. This is a small case scenario of this disease. I hope you will get benefit from the lecture, and thank you very much.